Thank you. All right. I think almost everyone here knows me. I'm Joseph Lee, and I'm one of the chief residents. And so today I'll be talking to you about surgical simulation and otolaryngology. And I also want to thank everyone here for being here and listening to my talk. All right, so let's start out with a really basic question, which is, what is surgical simulation? So a broad definition could be any technology developed to simulate surgical procedures for the purpose of training medical professionals without the need of a patient. So this could include anything from the time-honored pig's foot to plastic physical models and to what the focus of more recent research has been, completely computerized virtual surgical environments. And then the next basic question is, why surgical simulation? And simulation technology has been around for quite a while. For example, in the aviation industry, where it's quite well accepted. But does simulation make sense for surgical training? Well, actually, it's becoming increasingly common in surgical training, and particularly in specialties like general surgery and urology. It's in quite common use. And in ENT, it's been slowly gaining more attention and research interest. So you can see here that over the last couple of years and, last decade, and particularly the last couple of years, the number of ENT surgical simulation-related publications has been on the rise. But we all know that generations of otolaryngologists have been trained before the development of surgical simulation. And they were trained on this classical model where they participated in the care of real patients with a gradual increasing amount of responsibility. And it's basically this master and apprentice model. And as the saying goes, you see one, you do one, then you teach one. And so really, what's so compelling about surgical simulation? And why now? Why all the recent interest? So hold that thought. Let's think about the opposite or the reverse question. Why not surgical simulation? Well, the pessimist could say a lot of things. One, again, that training has gone on for a long time without it. So why try to fix it if it's working? And then, how could you really compare any sort of simulation with the real thing? And these surgical simulators, are they even effective at teaching real surgical skill? Or are they just overpriced video games? So surgical simulation technology may seem unnecessary right now, but I think changes have occurred and more changes are on the way that are affecting surgical training and may start to compromise that traditional training model. So there's the fact that, and we were just talking about this, the increasing overall cost of healthcare. There's increasing pressure to be efficient in our delivery of care and to deliver more care in less time. And inevitably, this results, unfortunately, in less time that we can devote to, really fostering that master and apprentice relationship and devoting more time just to education of trainees. And then there's the advent of resident work hour limitations. This is also cut into the total time a trainee can immerse him or herself in the learning environment. And some even estimate that as a result of the work hour limitations, it was equivalent to shortening residency by 1 year. And there's this increasing awareness on the part of our patients that that trainees participate in their surgical care. And it's not uncommon at all for our patients to ask us preoperatively if the attending is going to be performing the entire procedure. So it's not the norm at all for patient preference to directly dictate the level of resident participation in a case. However, it is fair to say that over the last couple decades, I think the trend has been towards less resident autonomy in surgical training, and for multiple reasons, including patient concern, perhaps, patient safety, quality of care, legal and ethical considerations. And also, it's increasingly difficult. It's increasingly difficult to obtain cadaveric material to practice surgical technique in the laboratory setting. Fewer individuals are consenting to donation. Proper disposal of cadaveric materials and maintenance of the training labs is very expensive. And then the practice of surgery itself is becoming more complex, with increasing numbers of the types of surgeries, the expanding number of surgical subspecialties and surgical techniques. There's minimally invasive, robotic, endoscopic. And so all of these new techniques have been developed, but with each new approach, for the trainee, it means more techniques to learn, but perhaps fewer cases to learn from. So, okay, perhaps there's no crisis right at this immediate moment, but surgical practice and surgical training are slowly changing so that the development of an effective surgical simulation technology, which could allow for cost-effective surgical training to take place outside of normal clinical practice without involving any real patients, living or cadaveric, would definitely be a good thing. So looking back at that pessimist argument against surgical simulation, if we're convinced that there's a need, or at least there's going to be a need, what now remains to be proven is that surgical simulation is actually effective. I think surgical simulation technologies are clearly getting better. There's increasing numbers of publications on the topic, and it reflects the growing body of work that's trying to demonstrate its efficacy. So to prove that a surgical simulation technology is good enough, again, a basic question, what defines good surgical simulation? Well, the simulation literature has adopted several types of criteria to try to determine this, and it's known as types of validation. So number one, does the simulation look and feel like real surgery? They call this face validity. Does using the simulator actually require real surgical skill? This is called content validity. Does performance on the simulator differentiate its users based on known real surgical skill? So in other words, if an attending is using the surgical simulator, will they perform better than a novice? They call this construct validity. And then lastly, does using the simulator actually help in real surgery if studied in a prospective fashion? And this is known as predictive validity. So at this point, I'd like to review some ENT surgical simulation validation publications, and in the process, give you some specific examples of the simulators that have been developed. So let's take a look at this article. It comes from the University of Toronto, and they developed an artificial temporal bone for surgical simulation, and they wanted to try to study the face validity of this platform. So what did they do? They took a high-resolution CT scan of a cadaveric temporal bone and turned it into a 3D printed model. They say that the most time-consuming step of this process was that they had to hand-select some of the key structures within the temporal bone, like the facial nerve, the sigmoid sinus, ossicles, and so on, slice by slice in the CT scan so that it would be printed in a different color in the final product. So you can see pictures of it here. They applied some latex paint over the top of it to simulate dura. And also of note, the cost per bone is $83. So what do? They sent this model out to 8 fellowship-trained otologists. Actually, I think Dr. Blevins was one of them. He's not here right now. And they were asked to drill on the model and rate its anatomic realism of its various structures. They were asked to comment on how the model sounded as it was being drilled on, and how the model behaved when with irrigation and suction. And they were also asked who would benefit most from training on this model. So let's take a look at the results. As is typical for these types of studies, the responses are recorded on a scale of 1 to 5. They call this a Likert scale. And so we're looking right now at the scores for anatomic realism. And so you can see that the model scored well for some of the more lateral, larger structures like the cortical bone, mastoid air cells, sigmoid sinus. Did not score as well for some of the finer structures. So you can see facial nerve, semicircular canals, and the chordae tympani on the other side. The model didn't score well for acoustic realism. And then regarding its irrigation properties, they commented that whatever this material that they used to print the bone, it tended to clump and stick together. It didn't really form a powder as you would expect in a real bone. And instead of irrigating it away, they had to pick it out with a pick. So again, losing points for realism there. And then they also commented on the haptic realism, which relates to how the model feels as it's being drilled. And again, the scores show that some of the outer structures show better results, and some of the deeper structures, well, they commented that the structures around the otic capsule weren't as firm as they should be. And then finally, in response to who would benefit most from the simulation, most people thought that it would be most suitable for a medical student or a junior level residents. So in summary, when it comes to studying face validity, we can see that it's assessed by a survey of expert opinion, essentially. And that in the case of this 3D printed high resolution model of the temporal bone, there are some strengths, but also some significant limitations when you compare it to the gold standard, which seems to be in this literature interchangeably considered either cadaveric temporal bone surgery or real surgery. So let's take a look at another study. Then this one comes from Georgetown University. And so in this study, they set out to create a low-cost sinus surgery task trainer. And they certainly used low-cost materials here. What did they do? They took a Dixie cup, and they made a Dixie cup-shaped depression in a gelatin mold. Then they put some beads in the back. They stuck some suture up in the top. They took a punch biopsy and just made a little hole on the top, and they called that the frontoethmoid recess. They also deposited an egg in there.
Is that the orbit?
That's a maxillary sinus. So so the trainees, they can use this to practice their endoscopic techniques, perform various tasks like probing the frontoethmoid recess, grasping, injection, suctioning. Again, the egg is supposed to be, I guess, an opacified maxillary sinus.
Yeah, don't laugh. Davoud has a sponge in his carotid simulator. Right?
That's right.
It's a real sponge.
Metrics too. The nerve resistor is giving you data, so
Making the most of what you got.
That's really going to be the first of its kind when you publish on that, so that's good. In any case, so they sent, they had 10 attending otolaryngologists work on this simulator, and then they asked them to fill out a survey, which, again, the intent was to try to assess the content validity of this simulation platform. And so, again, the survey answers are based on this 1 to 5 point scale, and it varies from strongly disagree to strongly agree, 3 being kind of neutral. And then, if you take a look at these questions, you get a sense of, the types that they're asking. Does the model help with camera skills? Does it develop hand-eye coordination? Is this a valuable training exercise? And so if you look at the scores, they do fairly well on most questions. And based on this, the authors conclude that for the development of basic endoscopic sinus skills, this simulator does fine. We can highlight an area where they thought the simulator was lacking, and that was in that frontal ethmoid recess area. They didn't think that that was a very valuable exercise. Looking at the rest of the questions, again, the simulator scores fairly well. They generally endorse it as a training model for mostly novice residents. And of note, in this last question, does the model mimic actual sinus anatomy? Well, they didn't score as well on that one, understandably.
Checking the right question.
So to summarize, the obvious strength, I think, of this platform is going to be cost, right? Anyone with some cheap materials and some time can make it. Survey respondents thought that it'd be useful for developing basic sinus endoscopic skills. It has obviously poor face validity because it doesn't look anything like sinus surgery. Although, to be fair, I don't think that was a major goal for these investigators. So let's take a look at another example. Now, in this one, this is from the UK, and this time they're assessing construct validity of a simulator. They use something called the Voxelman temporal bone simulator. Now, what's that? It's a commercially available, all-in-one temporal bone surgical simulation package, including 3D display, goggles, haptic force feedback controller, computer and software all included. And for the visuals, it uses a graphical rendering technique called volume rendering. And if you've ever ordered a 3D reconstruction of a CT scan for like a trauma case, it's essentially the same technique. The difference being in this setting, the visuals are rendered at interactive frame rates, so around 30 to 60 times a second. And it's worth noting that the computer hardware necessary to power these kinds of visuals has only been developed in the last couple of years, and actually it's probably sitting at home on your desk or it's in your laptop bags right now. That is to say, the computing power for these simulations has really come a long ways and is now quite affordable. And so again, the simulator provides high-resolution volume-rendered images of the temporal bone viewed through 3D glasses to provide some depth perception. You see the handpieces there. These are haptic instruments designed to simulate the act of using a drill with the expected forces and vibrations and pressures of actually drilling. And the simulator also is able to record a number of performance metrics automatically within the software, such as total time to complete a task, whether critical structures were injured. Now, how did they study construct validity? So they had 3 groups of participants. They had complete novices, basically folks without any sort of experience. They had an intermediate group, which consisted of mainly residents, trainees with some temporal bone experience. Maybe they drilled on one bone or they had participated in about 10 mastoid surgeries. And then they had the attending group. Essentially, they had done a minimum of 100 primary mastoid cases. And so they had all these participants watch an introductory demonstration video, kind of showing them how the software works. And then they were asked to, everyone started out with the image on the upper left. So the cortex has been removed, and they were asked to delineate the sigmoid sinus. That was a task. And here are the outcome measures. How well did they expose the sigmoid? What volume of bone was removed? Was the sigmoid or dura? Facial nerve injured? How quickly were they able to complete the task? Excessive force near critical structures? Again, all measured in a computerized fashion. And this, by the way, illustrates an important highlight, I think, of these virtual simulation platforms, is that you can measure all of these things automatically. So here's a summary where they saw statistically significant differences. And not surprisingly, there are significant differences when you compare a group of complete novices versus someone with at least a little bit of experience. And more interestingly, if you compare the intermediate group to the group of experts, 2 areas of difference arose: injuries to the sigmoid sinus and what they term efficiency. Unfortunately, in this publication, they didn't describe in detail how they calculated efficiency. But to summarize this one, So when it comes to construct validity, they assess this by measuring and comparing simulator performance between groups of users with different surgical skill. And again, I just want to highlight that the computerized virtual simulation platforms have this advantage of being able to automatically measure some performance metrics, and also no recurring material costs. You buy it once and then you just keep using it. Unfortunately, and particularly when it comes to these commercial simulation packages, they can be quite expensive. This one, again, the Voxelman, it's developed in Germany, and it costs $33,000. Okay, so we just reviewed 3 validation studies, and these are fairly typical of the validation studies in the simulation literature. We could continue to look at them. Let's take a bird's eye view of the simulation literature or simulation field in otolaryngology. This is a systematic review of all ENT simulators. This was done in 2012. Interestingly, the first publication on simulation they found was in the 1970s, and it was a physical model for intubation. But since then, what they found was that there have been 16 otology-related simulation platforms, 10 rhinology-related platforms, 8 related to performing procedures in the oral cavity, 8 cricothyroidotomy simulators, 13 bronchoscopy simulators, and then they had this kind of outlier group as well. So this doesn't relate to the number of publications. This is just if you have, if you develop a single simulation platform and then you can publish and do multiple validation studies, that would count as one. Apologize for this big table with small text. I'll point out the highlights. So in this table, it just shows you all 16 of the otology-related simulation platforms. And so 12 out of 16 of these are related to drilling the temporal bone. So clearly that's an area of high interest. There are also 2 myringotomy simulators and 2 ossicular prosthesis kind of trainers. And most of these simulators are computerized simulations rather than physical models. The 2 ossicular simulators are physical models, and one of the 2 myringotomy simulators are physical models. Only 3 of these products are available for purchase, and the rest are prototypes or kind of homemade constructs that, there are only 1 or 2 that exist, and usually at the home institution. And the good thing is, when it comes to otology, most of these have undergone some sort of validation study. What about rhinology? Well, most of them are endoscopic sinus surgery simulators. There are some epistaxis trainers and some general nasal anatomy models as well. About half of them are virtual, half of them are physical models. None of them are available for purchase, and only 1 has undergone any significant validation study. And then in the oral cavity group, a bit of a more mixed bag. 3 tonsillectomy simulators, 2 cleft palate repair simulators, and kind of 3 general anatomic models. Almost all of them are physical models. Almost all of them have undergone no validation. I'm going to skip going over the cricothyroidotomy and bronchoscopy groups. I don't think they're of as much interest, and also in the interest of time. So looking at otolaryngology simulators as a whole, you can see that it's quite a diverse group of simulation platforms utilizing a variety of technologies and in various stages of development. Unfortunately, most are in this kind of prototype or initial construct stage where they haven't really meaningfully looked at the validation. And the most recent, most robust research has really been focused on the virtual reality temporal bone simulators. So again, of the 4 types of simulation validation, we've reviewed studies looking at the first 3. And just to remind ourselves, the ultimate goal here is to establish that the simulations are good enough for prime time, so to speak, for wide-scale use in residency training. So we have to ask ourselves, are these studies sufficient? Are they really meaningful for the purpose of establishing whether these simulation platforms are ready for prime time use. Unfortunately, I think when you think critically about these studies, it's kind of easy to spot some problems. So let's think about the face and content validity studies. And again, they're assessed by these questionnaires. And actually, there's no standardization at all when it comes to the questions. It's up to the study designer to pick the appropriate question. And frankly, I think it's easy to pick the words and phrasing for these questions that's more likely to give you a higher score. So recall in this study that we looked at earlier, it was a low-cost sinus surgery trainer. And so looking at these questions, develop camera skills, develop hand-eye coordination, develop endoscopy skills. I think as long as your model involved some use of the endoscope and some use of your hand, it's difficult to answer no. And from the standpoint of determining whether or not a simulator is ready for wide-scale use, I think a study like this kind of sets the bar a little too low. And then furthermore, even if you have a high score, what score is high enough to consider it a successful validation? Well, nobody's really answered that. And then there's actually a lot of bias in that the respondents for these questionnaires are usually individuals known to the investigators or actually colleagues working even sometimes in the same department. So consider again, remember that same simulator, the low-cost surgery simulator. And let me remind you, it's a Dixie cup-shaped cavity in gelatin. And so in response to this question, is it able to mimic actual sinus anatomy? On this 1 to 5 scale, they gave it a 3.1, which is just a little bit better than neutral. I mean, I find that hard to believe. So I think the most persuasive type of validation study is going to be this predictive validation, which again, it studies in a prospective fashion whether a simulator actually improves real surgical skill, real performance. And for obvious reasons, I think this is the most difficult one to study. It takes a lot of expenditure of time and energy, and there are very few simulators that have had its predictive validity studied within ENT, unfortunately, and I'll review them quickly here. So the first comes from Ohio State University. This is a predictive validation study based on virtual temporal bone surgery, again, similar to the Voxelman. This is a fairly state-of-the-art 3D volume, rendered visuals, haptic controls, and runs on commodity computer hardware. So this is, I think it was quite an ambitious study. It was multi-institutional. It involved 60 participants, all residents. And so they had the participant first drill an initial cadaveric temporal bone, and then
It was also NIH-funded R01 study.
Yeah, that is correct. So all the participants, they drill an initial bone, and that gets scored. And then there's a assignment to either the traditional training arm, which is a 2-week, they call it a 2-week course of a traditional cadaveric temporal bone training, or a 2-week course of virtual reality temporal bone simulation training. Then after that, the participant drills another cadaveric bone, and we get to see the results. What were those results? Well, if you take a look at the paper's conclusion, you can see this quote here: there is no statistical difference between practice on the simulator compared to practice on human cadaveric temporal bone drilling. I think the real answer is that it's more complicated. And despite this is a very ambitious, large expenditure of time and energy in the study, when you dig a little deeper, it's flawed and it's hard to draw any conclusions. And let me try to explain. So let's take a look at the actual scores that the participants got. So you can see here, so look towards all the way to the left side. In the average of the assignment scores, the simulated group got 9.3, and then they go through their training, and then afterwards, what was the result? 9.3 again. Interesting. And then in the traditional group, the pre-score, 8.2, and the post-score, 10.5. So some interesting questions to be asked here. Why did 2 weeks of simulator training fail to increase the scores at all? So both arms were equivalent in terms of their residency training level and prior surgical experience. They tried to account for all of this. And of note, that difference in the pre-scores, so the difference here, 8.2 versus 9.3, this was found to be statistically significant. So again, I want to bring your attention that in the traditional group, the score increased from 8.2 to 10.5, which is a difference of 2.3, and then there was, zero difference in the surgical simulation group. But they claim that this difference here, so the difference in the delta that was achieved from pre to post in these two arms, they found this to be not statistically significant. And based on that, they were able to claim that there was no difference between the two training modalities. And it's also notable for both arms. They stated 2 weeks of traditional training and 2 weeks of the simulation. Well, actually, in the traditional group, they were only given access to 2 temporal bones. And in the simulation group, they were allowed to drill 10 times, 10 virtual bones. And they don't actually measure how much time within those 2 weeks these residents actually spent, training. So I think it's a little bit hard to interpret those results. Let's just move on to the next study. So this work comes from the East Coast. They looked at virtual reality sinus surgery simulator. It's called the ES3. This is the one that's been the best validated and best studied. And it was developed by the U.S. Army researchers in collaboration with Lockheed Martin. You can see them using it there. And how did this work? 25 trainees with 0 sinus experience. And they were randomized to either full proficiency, they call this full proficiency, although they don't really define what that is, on the simulator, versus a traditional training regimen, which consisted of the usual textbooks and educational videos. And then following that, in the participants' first sinus surgery, the performance was video recorded and scored. So here's a table comparing the simulator versus traditional group, and let me just point out some of the things that they try to measure here. Injection time, dissection time, number of injection errors, surgical confidence. You can see this all has to do with kind of technical skill. And then, without don't worry about looking at each of these numbers. Let me just tell you that in the simulator group, they performed better than the traditional group in every single category. And all the differences were statistically significant. But unfortunately, I think this is an entirely predictable result, because remember, all the participants are completely naive to any sort of endoscopic sinus surgery. And then this was followed by either a simulator-based training versus a traditional training which involves no development of hands-on technical skills. And then the final assessment was mainly a test of hands-on technical skill. So I think it's no surprise that the difference is seen here. And I think that, again, I think the bar is set quite low. A simulator would have to be quite poor not to show a difference in this context. And I think even the Dixie Cup gelatin simulator would have shown a statistically significant difference. So one last paper. This is from Australia this time. They studied another virtual reality temporal bone simulator. This is actually a commercial product called the Medusius. Interestingly, this company seems to have gone out of business. Can't find it anymore. And I couldn't find a price quote for this product, but I do know for a fact that these two haptic devices, which of course is only going to be part of the cost, is at least $20,000 alone. So it's going to be quite expensive, probably comparable to the Voxelman that we saw before. So in this study, they took 20 rookie residents. There were 12 with essentially no temporal bone experience, 8 with minimal experience. And the participants, all of them had a 2-hour course on temporal bone anatomy and some surgical approaches. And then they were randomized to either 2 hours of supervised teaching on the simulator or 2 hours of kind of small group traditional teaching, going over CT scans, looking at videos of surgeries, etc. The final test was to perform a canal wall down mastoidectomy on a cadaveric temporal bone. So what I like about the study is that they really took a look at several different categories of performance. They have this end product score, which is kind of a reflection of how well the mastoid was skeletonized. How does everything look at the end? And then they have this injury score, which is a reflection of whether or not any of the critical structures were harmed or whether they were preserved. They also have a technical techniques, a technical score, which measures surgical technique, and then an overall score. So when it comes to this top portion, you can see that there were statistically significant differences. The simulator group did better in all the categories with the exception of this technique score, which was approaching but not achieving significance. And then when you break down the mean product, or I mean the end product score and the injury scores by anatomic subsite, you can see that most of the benefit appears to have come from how the trainees were handling some of the more medial structures like the semicircular canal, the facial nerve, same thing in this bottom category. Like the other studies, this one I don't think is perfect, and the devil's in the details. So recall that the two study arms are either 2 hours of supervised instruction on the simulator versus 2 hours of small group kind of traditional teaching. So what do they mean by supervised instruction? Well, it turns out that each participant in the simulator group gets a one-on-one instruction by an attending while using the simulator. And I think it's hard to quantify, how much, sage wisdom is being given to that resident during that 2-hour one-on-one setting. And so how much of this is the effect of that one-on-one training versus actually using the simulator? Well, it's going to be hard to tell. So clearly, we need more high-quality predictive validation studies in ENT simulation. And well, let's ask ourselves the question, how does our current progress compare to general surgery? Well, in general surgery, most of the research and development has been on laparoscopic simulators. And they have a lot more higher quality prospective validation studies. They have enough to have 3 different systematic reviews on the topic, and they have a meta-analysis, they have a Cochrane review on just these high-quality studies. And so, I think it's well accepted that that simulation technology be used in general surgical education. And they've even gone the next step, which is linking simulation training to not only better surgical performance, but better patient outcomes. They've looked at the incidence of operative complications and the length of postoperative stay. So multiple reasons why we lag behind other subspecialties. Compared to general surgery, I think it's important to note there's no such thing as a cadaveric bowel lab. And really, when it comes to temporal bone surgery, we have cadaveric temporal bone drilling, and that is a standard that virtual reality simulation will have to meet and beat because it's available to us. And there's also the fact that in general surgery there are more programs, more residents. And so perhaps the financial question of whether or not it makes sense to invest in surgical simulation is a little bit easier when you're in general surgery. And then I mentioned chicken and egg because, well, it would certainly be a lot easier to study this in greater detail with better studies if we had more simulators and more residents using them. But it's hard to justify the expenditure and investment in time and energy to set up these virtual simulation environments without some better studies. So we're kind of stuck. So at this point, I'd like to sum up the key points from my presentation and give you some final thoughts. There have been many different types of surgical simulation technologies developed in ENT, but the vast majority are prototypes. They're kind of homemade constructs, one-of-a-kind examples, and many of them have had no validation. With regards to the validation that has been done, oftentimes, they're flawed in their study design, or they have problems with bias. And the highest level of validation, which I'd consider predictive validation, is also the most time-consuming, most difficult to perform. Few of these studies have been done to date, particularly in the ENT literature, and some of them compare training to no training at all, and they set the bar too low when they look at the study results. And the one that does compare simulation to traditional temporal bone drilling, which is really the question we have to ask ourselves when it comes to temporal bone simulation, is frankly unconvincing. And right now, there's no urgent need for surgical simulation to be rapidly incorporated into training curriculums. However, again, there is potential that the surgical training is changing, and there may become a greater need for training outside traditional real patient care settings. And it may make sense as simulation technology and their validation studies improve. I think the most likely area where simulation will get its foot in the door, so to speak, is going to be for the introduction of temporal bone surgery to naive trainees in master surgery, perhaps in sinus surgery if those simulation platforms can catch up. And there are definitely positive aspects. It can accelerate the acquisition of basic surgical skills. It can really accelerate a resident's climb through the surgical learning curve. And then hopefully allow a resident to gain even more benefit from the involvement they have in real surgeries. And in my opinion, surgical simulation will never replace real surgical experience. And finally, I'd like to talk a little bit about the future possibilities for surgical simulation. What's possible beyond just simple surgical training? Well, number one, there's increasing interest in research into what's called patient-specific surgical simulation. So this is where you can actually take a patient's own, individual imaging and use that to create the simulation. And so you can actually perform some preoperative surgical rehearsal. And virtual temporal bone simulators are particularly well suited because many of these patients already have CT scans anyway. And so studies on this topic are on the way. Right now, the focus of surgical simulation is on the acquisition of technical skills and anatomic and procedural knowledge. But in the future, I think as simulators become more sophisticated, they could include kind of scenario-type learning to develop some of the non-technical skills, such as communications, teamwork, situational awareness, decision-making, leadership, and so on. Surgical training under the master and apprentice model, can vary quite a bit from program to program. We know that, even from resident to resident within a training program. And I think if surgical simulation becomes more accepted and then becomes standardized and then really refined to incorporate the best educational techniques, it could potentially raise the standard for training nationwide. And then finally, as simulators become more sophisticated and accepted, there may be a role for simulators to play in certification of training. There are already simulators that assess automatically various aspects of performance. Simulators perhaps could play a role in selection of residency candidates. But of course, we're a long way from that right now. And that's the end of my talk. Thank you very much. Yes.
So how quickly are these systems progressing toward to rehearsal surgery? The reason I ask is that neurosurgery has had one of these, which was very credible, for probably 6 or 7 years now, and it just lies dormant. Nobody's used it.
You mean they have a platform that's capable of loading a patient scan and performing surgery on it?
You can co-register MRI and CT.
Yeah.
And 3D virtual and rehearse surgeries.
Yeah.
And nobody used it. It's lying vacant.
Yeah. Well, in terms of the development of the platforms that are able to perform surgical rehearsal, it's already there. There's just a lack of literature really studying it in a rigorous fashion. So if you try to look for any literature right now, looking at prospective studies of preoperative rehearsal, I don't think there's anything out there. But you can totally do it.
I thought that was a really good grand rounds. I like the way you went through the papers and reviewed them and gave your own assessment of the strengths and weaknesses.
Thank you.
So I agree with everything you said. So anybody who's played Call of Duty knows you can get into the game, right? I mean, the graphics is there. Come on, Rod, you've done it.
You know, it just occurs to me, if I can, I know you're in mid-thought, the captain of the Malaysian 777 aircraft had a simulator at home, and for pleasure, it sounds like a busman's holiday to me, would go home and would fly a plane on a simulator. Will we ever be going home recreationally and doing surgery?
I think that's the point. I mean, you can get into it, and it can be enjoyable, and it can be realistic. Right now, the problem is the haptics, right? The haptics stink. They're so expensive. And how can they make them cheaper so that there's a role for regular games to have haptic devices?
Yeah.
Then you'll start seeing good surgical simulators.
So with respect to the cost, it is true that the haptic devices in these virtual simulators, the haptic cost is very high. For a really high quality haptic instrument, the cost is upwards of several tens of thousands of dollars. And so if you look at all the other costs, like the display and the goggles and the computer, that pales in comparison. That you can get that for a couple K. And why are these things so expensive? It's really, I think it's supply and demand and market, economics. There's just not enough demand for it, and there have been some lower cost haptic devices. There is a product called the Falcon Novint, and they tried to really gear it towards the gamer community. They developed drivers so that you can play some of the more common or more popular games during the time it was being touted, and it really didn't garner too much interest, unfortunately. I think as computer technology improves, I do have hope that maybe there will be more progress in that direction. There's things like the Kinect. There's more attempts for the gaming industry to involve alternate controller inputs, so like the Wiimote, and so. But with respect to haptics, not quite there yet.
Well, I would just say that, in terms of the difference between uptake of this kind of technology in medicine versus aviation, one thing is built into everything they do and every workflow that they've ever had in aviation. It's part of their job. It's used on a recurrent basis. That's because the airlines figured out long ago that the value of spending a lot of money on simulation far outweighed the cost of having pilots crashing airplanes. And the cynical point of view on that is that's bad business, right? It's very bad business to crash airplanes. We crash a lot of airplanes in medicine and healthcare every year. It just happens quietly. And
the surgeon doesn't go down with the plane.
That's the other very subtle thing that doesn't That's what we said. The basic thing is that they don't, our workflow and our training and our program of practice just doesn't incorporate this kind of flow. So I think until it's sort of incentivized and the value of it is known, it's not going to happen.
When you were flying commuter airplanes, did you go home at night and fly in a simulator?
No, I did for the first year, and then I did not. When I came home and read about medicine.
Hey, Joe.
Yeah.
So, a great talk. I really enjoyed it. Just to add to what Dr. Otolaryngology said, it was a great talk.
Thank you.
I've been an aviator and a surgeon for decades, and really this was a talk very close and dear to me. And I've used simulators in both aviation as well as, in surgery. As Stu also said, the big difference in the aviation is just severely incorporated in our fabric. I mean, I use a simulator even though, I just fly for recreation on a regular basis. At least once a month, or 2 months, once every 2 months we're using a simulator, if not more.
Yeah.
The biggest difference is that in aviation, the simulators are all scenario-based. the pilots go through the phase of learning how to fly very quickly, and so they don't simulate takeoff, cruise, and landing.
Yeah.
They simulate what happens in an anomaly. And I think in medicine, we don't have that capability right now. Our scenario, our temporal bones may give us a little bit of an anomaly once in a while, but you don't have an instructor sitting next to you while you're flying and suddenly he pushes a button and you're trying to land and the landing gear doesn't come down.
Well, they have that in
So-
anesthesia. They have like a
Right.
cardiac emergency or.
So I think that's what we also need.
Something
We
like
need
that.
scenario, as you also pointed out, scenario-based and also intellectual simulation rather than just technical. Because we will all learn how to do most of the stuff that we do. And well-trained surgeons usually don't get into trouble in a normal case. If you always look at the M&Ms, it's always because the case, there was something weird about that case.
Yeah.
And even experienced surgeons, I've had some years that I sweat. And I say, is this thing going to end? I mean, am I going to end this case? Am I going home today or what? Because it's just a series of anomalies in that case.
Yeah.
So we need a simulation basis that the instructor or could be your attending sits next to you and pushes a button and something bad suddenly happens.
Yeah.
And then what do? You're trying to remove the stapes and everything comes out. Now what do you do?
I totally agree. I think a really good idea would be developing a depository of interesting temporal bone CTs, which could then be loaded into a simulation platform, and they could comprise a number of different interesting anatomy, just so that you can run through all of them and kind of see what's been out there surgically historically. The problem right now is just getting the simulator part up to spec. It has to look good, it has to feel good. Correct. And right now, it's not quite there yet.
I feel like the resolution of a lot of the CT scans is high, but if you made the resolution high enough, when you radiate a patient, that would be very bad for the patient in order to actually get the simulation volumetric 3D, resolution high enough to really simulate a very realistic. I look at these models, even with the most high resolution CT scan or something, I'm like, that is the most rudimentary looking 3D rendering.
Yeah.
In my opinion, I used to be a professional 3D computer graphics artist, but we could make the rendering appear better, definitely, but I do agree with you that the haptics is a huge issue. And getting dynamic simulations, like being able to eventually simulate blood flow, powder, and everything. There is visual graphics effects software out there that does all of that stuff, but to be able to incorporate that in would be really cool. And liquids and fluid dynamics and stuff.
Yeah. Agreed.
It's out there. It's just,
Are you volunteering?
I'd love to volunteer.
Great.
Absolutely.
Thank you.
All right, very good.